Good evening, and thank you for attending the second of what I hope will be monthly classes where we talk about a dramatic new technology that's forever changed the way that we manage diabetes. We're going to be talking about a device called the Freestyle Libre, and we're going to be looking at the reports that can be generated from this device. And what I hope to do is twofold. One, to help you, my patients, my clients, and loved ones to learn how to use this device to improve outcomes, not just get your sugars or your A1Cs lower, but improve the quality of life, avoid low sugars, and to reduce the burden of living with diabetes. We've chosen to do it with Facebook Live, one because I'm kind of a tech nerd, and it's nice to know that people might actually be watching. Secondly, so that we can record this for teaching purposes. So here at BC Diabetes, we have 3 BC Diabetes clients and one of their friends, and I expect that we'll be interacting throughout the time. I expect this to be over within an hour. I have 25 slides, but I've never presented it in this forum before, so let's go. We're going to talk about the Freestyle Libre and specifically about interpretation. We're going to look at the factors that make sugar go up and that make sugar go down. We're going to talk about medications, pills and insulin, and how they can influence that. Then we're going to look at the Freestyle Libre itself, at what it measures, look at the patterns that we sometimes see, and then talk about how we can fix those patterns. And then finally, I expect to have an open discussion. My name's Dr. Tom Elliott. I'm the Medical Director of BC Diabetes. But I don't work on my own. I have a fantastic team of staff, 14 and counting. Not all of them were there in this picture, but all of these are experts in what they do. Whether they meet you at the front office, whether they make the booking, whether they're a case manager working with you, a dietitian, a pharmacist, or a physician, or whether you're involved in research. My team at BC Diabetes makes it all possible. Let's start with what makes sugar go up. I think it's important to think about this because ultimately, we think about the Freestyle Libre, we think about adjusting insulin, but I want all of you to remember that there are factors other than insulin that we can actually control. So let's start with food. The food that makes the sugar go up fastest and most quickly is sugar itself, but followed closely behind sugar are what I call white foods. So that's white rice, white flour, white bread, potato. If the food is white, unless it's cauliflower, you probably should be exercising some restraint in its consumption. So obviously we need to eat. So we're going to try to fill up on grains and vegetables, and then depending whether or not we eat meat, we may choose to eat meat. All of those foods eventually are going to turn into sugar. I put fat in brackets because fat does not turn to sugar. Fat's very high energy, but it does not make sugar go up. So the bigger the helping we have, the higher the sugar is going to go. And the more to the left, the more like sugar or the whiter it is, the higher and the faster our sugars are going to go up. Well, I think we've all noticed that when we're sick, when we've got a cold or the flu, our blood sugar is going to go up. So that's something we can't control, but at least it's something that we can identify. Sick days. And then if we're anxious or stressed out, if we're emotional, if we've just had a fight with our girlfriend or boyfriend or husband, or an accountant or a lawyer, we know that these things will make the blood sugar go up. And the reason for that, just like sick days, is that our body releases hormones called counter-regulatory hormones, hormones that do the opposite of insulin. So that's cortisol, it's growth hormone, it's glucagon, it's adrenaline. These hormones all make sugar go up, and they're released when we're sick or stressed. Young women will notice that in the week prior to their period, their sugars will be higher as well. And then finally, I mentioned the liver. The liver and also the muscles are sugar factories. So when we're fasting, our body needs to get energy from somewhere, so it gets it from the liver and the muscles. In diabetes, in type 2 diabetes, the liver tends to make too much sugar overnight. So that's one other factor that you may notice, that your sugar's higher in the morning than it was when you went to bed. You didn't eat anything. What's going on? Well, that's your liver making sugar. And finally, I mentioned exercise. If we exercise maximally with cardio, so let's say we're running very fast or working out very hard, or if we're lifting heavy weights, our body is going to feel like it's stressed. It's going to release the same hormones if we're sick or stressed, and blood sugar will go high. Now, in the hours after this kind of exercise, many people notice that the sugar goes low, but I wanted to point out that certain exercise can raise the blood sugar. Well, what makes sugar go down? The one that I spend most of my time talking and thinking about are medications. Not just insulin that we'll spend a lot of time talking about tonight, but medications in the sulfonylurea class, glyburide and glycoside, drugs that I hope I never have to prescribe again in my life. They're very inexpensive drugs. They lower sugar very well in people who've still got some of their own insulin, but the danger of a severe low blood sugar is high, and so I don't like to use them. On the same list as medications that lower sugar is alcohol. So if enough alcohol is consumed, it turns off the liver's ability to make sugar, and low blood sugar ensues. So alcohol, I remember my surgeon in medical school telling me, Dr. Elliott, alcohol's a poison. Well, it is a poison. Some of us are able to handle more poison than others. But in the context of diabetes, it's going to increase your risk of a low blood sugar. Then we come to exercise again. So exercise, particularly if it's mild to moderate cardio, is actually going to lower our sugar if it's elevated. So if you want to gently lower your sugar, nothing beats a brisk walk or a jog or something like that. So we like exercise and we use it therapeutically. And then there are medical conditions that can dangerously lower blood sugar. When the liver is failing, when the adrenal glands aren't working, or when the pituitary gland is not working, we can also get low sugar. Those are things that I, as a doctor, need to look out for, not so much you. However, you can always ask your doctor, I'm having low blood sugar, is it because, my adrenal glands are not working? Well, what's the big deal about high blood sugar? The big deal about high blood sugar is that it damages our body slowly over the course, not just of days, weeks, and months, but over the course of years. So if you have a high blood sugar for more than 10 years, it's quite likely it's going to damage your eyes. And to check whether that's occurred, we always want our clients to have their eyes examined by an expert, a skilled practitioner. It could be an optometrist or an ophthalmologist, and that should be done on an annual basis. If damage to the eyes are found, then there are specific treatments that can dramatically lower the risk of blindness, namely laser therapy and injection with certain medications. High blood sugar also damages the kidneys. The first indication that the kidneys have been damaged by diabetes is the appearance of protein or albumin in the urine. So one of the annual tests your doctor will order is a UACR, a urinary albumin to creatinine ratio. If that's elevated, it suggests that there's been damage from sugar. The good news is that is reversible. And finally, high blood sugar over years can damage the nerves. The first symptom that people have is numbness in their feet. It can be pain, and that puts people at risk of ulceration, infection, and amputation. So if you've got, it's up to me and my staff to make sure we check you for nerve damage or neuropathy. And if it's present, you need to be especially careful to check your feet for ulcers, to check your shoes for little pebbles and rocks that might rub away at your foot if you have numbness, to cut your toenails, and to cut your toenails carefully. So high blood sugar damages the body slowly, low blood sugar damages the body quickly. As a physician, day to day, I worry much more about low blood sugars in my patients than high blood sugars. If I'm doing my job and the patient is, if I provide adequate education, access to medication and devices and advice, then as long as the patient is engaged in the process, then I know that their blood sugar is going to come down. What I worry about more is low blood sugar. Sugar is the fuel of the brain. When the brain runs out of fuel, bad things happen. We get low brain function. Low brain function, as the blood sugar lowers, it's a bit like getting drunk. The first thing you notice is that you're not thinking quite as well. You might think everything's funny. You might get agitated and pick a fight. But this could be an early sign of low blood sugar. If the sugar goes low enough, not only will you shake and sweat, but you may go into a coma, have a seizure, and if your sugar's low enough, long enough, it can cause death. Day to day, we worry about low blood sugar interfering with the ability to drive and judgment. So one of the rules we always have in our patients is to test before driving or operating machinery. And the saying is never drive under 5. So there's a moral obligation for everybody with diabetes, particularly those on insulin, to test before they drive. If the sugar's less than 5, they need to eat some candy, drink some juice, eat some starch to bring the sugar above 5 before they drive again. We're going to get to the nitty-gritty now, and I wanted to show you quickly a tracing of what happens to insulin levels in a person who doesn't have diabetes. Last time I checked, I didn't have diabetes, and I think this is what I could expect throughout the day. That blue line is the insulin level in my body. And the reason the insulin goes up is in response to me eating. Remember I said everything we eat except fat turns to sugar? Well, in a person who doesn't have diabetes, their body knows exactly how much insulin to secrete. It goes up very quickly and then comes down as the meal has been processed, digested and absorbed into the bloodstream. And you can see 3 spikes, one with breakfast, one with lunch and one with dinner. And then there's always a little bit of insulin around. So you've got mealtime insulin and then you've got a little bit of insulin called basal insulin. This slide shows you the same sort of information, but starts introducing the idea that we might be able to mimic it in someone who has diabetes whose body is unable to make insulin with a meal or even insulin between meals. So you can see the 3 peaks are meal related, and that's the point at which we would use a fast insulin. Give insulin sufficiently and in the right timing to prevent the sugar going high. And then the insulin that is along the baseline, we can also mimic with another type of insulin called basal insulin. And we're going to get to that now. What this slide shows you, it introduces to you the types of insulin that I, as your physician, have at my disposal to treat you. At the far left, we've got insulin, the brown one that's got a sharp peak. There are 3 of those on the market. There's insulin aspart, insulin blue lysine, and insulin lispro. That peak kind of looks like the peak that occurs in people who don't have diabetes. The next insulin in blue is called regular insulin. That was the one that was discovered by Banting and Best, the Nobel Prize in 1922. We hardly ever use that anymore because it's not fast enough. It's kind of flatter and rounder. And then there's that yellow insulin called NPH. That insulin is also kind of obsolete. The trouble with that one is it's not fast enough and it doesn't last long enough. And then in the purple, we've got a long-acting insulin called Detamir that lasts 14 hours. And finally, we have a very long-acting insulin called insulin glargine. So what we typically do in diabetes management is we use very fast insulins like the aspart, blue lysine, and lispro, and very slow insulins like glargine. Here we have a picture showing you 2 tracings. One in blue is the insulin, the natural insulin that is released in a person who doesn't have diabetes in the face of breakfast, lunch and dinner. And then in red are the tracings that come from using rapid insulin, you can see that they're kind of close. And what that tells us is, as long as we don't have meals that are very high in sugar and white food, the insulin release with our fast insulins is quick enough to take care of business. Well, I wanted to tell you just briefly what we used to do before we had CGM. We used to poke our finger, didn't we? And we would use two insulin. We'd use basal insulin, such as glargine, or a newer one called degludec, and we'd tell our patients, I want you to test your sugar every morning, and the target reading is between 5 and 7. If you wake up and your sugar's between 5 and 7, that means the dose of the basal insulin, the slow insulin, is perfect. If it's above 7, you need more, and if it's below 5, you need less. Gary, you can remember me telling you that, can't
Yes.
you? I know. And then with rapid insulin, we would say, I want you to take this fast insulin every time you eat, and I want you to take enough so that 2 hours after the meal, you're between 6 and 10. So that's the old style. Please come in.
Sorry, there's nothing I can do when the traffic is against you.
We have an arrival. Our patient Sagarudin. Welcome.
Thank you.
We're just starting the discussion. So that's in the olden days. We used to tell you, poke your finger in the morning so we know that the dose of the long-acting insulin is correct, between 5 and 6, sugars between 5 and 7. And then if you're taking fast insulin, test 2 hours after the meal. If you're between 6 and 10, everything's perfect. Well, I said earlier, we've had a revolution. Along comes CGM, or continuous glucose monitoring, and a related technology called flash glucometers. It caused an absolute revolution, because instead of having to poke our finger 1, 2, 3, 4, 5, 6, 10 times a day, all of a sudden we've got a device for which we don't have to poke ourselves, that gives our sugar hundreds of times a day, and by and large gives it to us quite accurately. I'm showing you there that bcdiabetes.ca is our website, and if you go to handouts, there's a search bar that you can type in anything you like, and hopefully you'll find an answer. I have a handout on CGM and flash that talks about a lot of the things that we're covering tonight. In brief, the revolution has led to better outcomes. We have better blood sugar control, we have better quality of life, we have less fear about going low in the middle of the night, we have fewer traffic accidents from low blood sugars. We have, if we wait long enough, we have fewer long-term complications such as damage to the eyes, to the kidneys, and to the nerves. So we have better outcomes. And we have happier patients with diabetes, PWD, people with diabetes, and their families. And then for someone like me, we have happier doctors, nurses, and case managers. We feel more fulfilled. We know we're doing our job because our patients are getting better outcomes. And that's why we had the fundraiser for BC Diabetes just over 3 weeks ago, where we raised $111,000 to help support patients who can't afford continuous glucose monitors. Okay, so I'm going to start talking now about the Freestyle Libre report. This is something that you can go online and you can produce these reports and either share them with the BC Diabetes staff, or you can download them and email them to us. And ultimately, this is the first page that we see. The slide is imperfect, but at the top, you can see that it estimates the A1C, and that says 6.5. So this is a 2-week snapshot, and what they're assuming is if this blood sugar control is maintained over 2 weeks, we're going to get an A1C of 6.5. Well, you know that generally we want an A1C less than 7, so 6.5 sounds pretty good. We found that these devices tend to underestimate A1C, often by 0.5 to 1, but even still, even if we add 0.5 or 1 to 6.5, that's not a bad reading. On the left, you can see average glucose. So there's a formula that takes, a Freestyle Libre measures the sugar every minute, and it takes the average 7.8, and then there's an arithmetic formula for estimating A1C. You can see below the average sugar the percent above target. Well, the target by default is between 5 and 10. So in this case, 16% of the time, the value was above target. Like I said, high blood sugar, it only hurts you if it's there for 10 or more years. So I'm happy with 16%. I'm not worried about that. I'm very interested in the time in target. This person is a superstar. Their percent in target or time in range is 76%. We think that anything above 60 is good and anything above 70 is very good. And finally, we look at what proportion of the sugars are below target. Remember, below target is low sugar. Low sugar can kill you fast. So we always look at that carefully. Now, I should add one more thing. Flash glucometers and continuous glucose meters don't measure the sugar in your blood. They measure sugar in your body juice or interstitial fluid. It takes a while for the sugar in the interstitial fluid to equilibrate to match the sugar in the blood. So if the sugar's going up quickly in the blood, the sugar in the interstitial fluid is going to read a little low. If the sugar's coming down fast, the sugar in the interstitial fluid is going to read a little high. And one thing that we notice is that the Freestyle Libre is not particularly accurate low down. So many people will say, doctor, you know, the Libre says my sugar's 3.4, I don't feel anything. They poke their finger and they find that their blood level is 4.8. That's a common phenomenon. The bottom line is that these devices may not be as accurate as blood meters, but they're wonderful for showing trends. Where has the sugar come from? Is it going up or is it going down? And that's much more important when we have to make a decision about what we're going to do about something. So we look at the average glucose, the percent above, the percent to target, the percent below target. The second one looks at low blood sugars. And you can see these little, even though it says the time in range is less than 5, it's going to consider anything less than 3.9 to be potentially serious. So here we can see a couple of events that have occurred, and you can see they're between 2.9 and 3.9. So we're always going to look at that. And then finally, we're going to look here at the sensor data capture. You know that the Freestyle Libre, it only stores sugar for 6 hours. So as long as you scan it every 6 hours, you're not going to lose any data. You can see this person only lost 4% of the data. That's pretty heroic. And you can see that they used to scan 7 times a day. That 7 doesn't come out, but that's what's going on. If it only stores for 6 hours, what happens if you sleep more than 6 hours? Most people sleep more than 6 hours at night. So inevitably, unless you get up for a pee in the middle of the night and scan, you are likely to lose some data overnight. And when we review the patterns, you'll see that happening. During the day, don't forget to scan, not just to look at your sugar, but to make sure that the data is transferred onto your reader or onto your phone. Okay, now it's time to get into the interpretation. I think you guys have all the information you need. So here we have, and you can see that Dr. Elliott has given you his kind of quick and dirty interpretation. It says breakfast high. And I think you can see, but let's remember, low blood sugars can kill you fast. Do you see anything below target? Remember, target's between 5 and 10. Rosalia, can you see anything below target? What about these readings? They're all below 5, okay? So they're potentially problematic. Remember I said the device is not that accurate low down. So we're going to make note of it, but we're not going to get excited about it.
Each dot represents a reading?
Each dot is one reading, subreading. That's exactly right. So these dots have accumulated over 14 days, measured every minute. And of course, it's not actually showing you every dot, but it's showing you average dots. Gary, do you Do you agree with Dr. Elliott that there's a problem after breakfast?
For me, no.
Okay, so here's breakfast. This person has breakfast around 7 a.m. and after 7 a.m. you get this. That's how you eat, Rosalia.
Yeah.
Okay, so you've got your Freestyle Libre. This is your tracing. What are your options? Are you being good? Are you on a diet? Are you eating grains and veggies, or are you filling up on bread and kanin and rice?
Yeah, I think I know now what is my problem in my breakfast, since
Yeah.
I eat around 12 o'clock my breakfast.
You eat at midday.
Yeah, midday. That's why. But
Okay.
I cannot do it.
So let's look at this person. So we always want people to make lifestyle changes first. You know, you watch the TV ads, the newspaper ads. Everybody thinks that eating a cereal from Kellogg's is the right breakfast. Well, all those cereals, even though they may be brown or made out of corn, they also turn to sugar very quickly. So they're not ideal. So the first thing we're going to do is think about our diet. Can we change our diet? What if we've worked hard on our diet, we're really being good? What are our options? Do you remember that slide where I showed you the fast insulin? Well, that's the time where we might consider using some fast insulin. We might also use some pills called the SGLT2 inhibitors, which tend to take the top off the peaks. Or we might use a shot called a GLP-1 agonist, which also help as well as reduce the appetite. So in this person, the only thing we see is that spike, and we're wondering about what they're having for breakfast, and we're thinking about starting some other medication, maybe fast insulin, maybe a pill, maybe a GLP-1 agonist. Okay, this is another patient now. This is the first page you see on the report. Ron, is anything jumping out at you on this?
Well, the estimated A1C
It's 4.2.
Yeah,
That's extremely low.
Yeah.
That's at the bottom of that's not even a non-diabetic person. What about all this red? Red is low. So this person is very low. You can see that 72% of the time they're below target. This is a disaster waiting to happen. And interestingly, this person didn't feel most of these blood sugars. You know, most people will tell you if their sugar's below 3.5, they feel it. This person's sugars bottomed out at 2.3, and still he only had mild symptoms of shaking and sweating. So some of this is due to the device not being accurate, but most of it is due to too much insulin. So some drug this person is on, and this is my patient, I know what medication they were on. They were on basal insulin and way too much of it. So the first thing we did was drop the insulin by 50%. And I can tell you that this did have a happy ending. His blood sugars did come up. You can see he only spent 28% of time in target, and he was never above 10, ever. All right. Here's another example of low sugar, but it's not quite as pronounced. You can see that we've got a pattern where the patient wakes up in the morning, their sugar's low. What are we going to do in this person?
Good breakfast.
Okay, Sadruddin, you're absolutely right. A good breakfast is going to make the sugar come up, but more than anything else, we're dealing with a low sugar. Low sugar always means too much medication. And in my business, it's generally insulin. So this person's on too much insulin. We did the same thing. We backed off on the long-acting insulin by about, not by 50% this time, but about, I think, 30 or 40%. and we were able to eliminate the low sugars before breakfast. But as you can imagine, doing that is going to make everything come up, and then you might get a spike of sugar after breakfast. So then we're back with the same patient before. What are you having for breakfast? do you need to change that, or do you need a different insulin or a different medication? Okay. Dr. Elliott says high after meals. So here's between 5 and 10. Oh, I want to show you one thing. So you'll notice that there are no readings between 9:30 p.m. and 11:30. What that means is that 6 hours later, the patient was still asleep, so we miss out on those readings get lost. You know, it's pretty obvious what's happening during that spike. We know that the sugars are coming down. But the obvious pattern to me when I look at this, David, do you see an obvious pattern here?
Dave.
Dave?
It's going down instead of up.
Yeah. Rosalia, what do you think about that?
Oh, it's quite high there.
Yeah, and it starts going up at about 5 o'clock.
Yeah, and all the way up to almost 10 o'clock.
Yeah, and this person has dinner at 5 o'clock. So what are we going to ask? We're going to say, what do you have for dinner? You know, can I come over to your place? It must be a really good dinner.
Big dessert.
A big dessert. Maybe it's a bunch of samosas somewhere in.
I don't know if samosas, maybe a cake.
Okay. Samosa followed by gulab jamun.
Okay,
Maybe.
that would do it.
Anyway, we need to think about what's happening at dinner. So in this case, once again, do we change the diet? Do we add a fast insulin for dinner? That's the kind of decision that I'm trying to make.
But if the tendency after that going up, then you will be low. So
Yes.
you will have fast.
That's a very good point, Rosalia. I mean, I know all these patients. I'm not giving you their names or information,
Yeah.
but this person is on a long-acting insulin. So we know that the dose of long-acting insulin is pretty good because they wake up and the sugar's not too bad. Okay? And then they have, you can see at breakfast the sugar goes up a bit, but it goes sky high at dinner. So what we actually did, this person started some fast insulin with dinner. And as we start fast insulin, we know it's going to come down later, so we often reduce the long-acting insulin as well. So when we raise one, we tend to lower the other, and ultimately, you know, we're not trying to fix it in 2 weeks. We're trying to gradually fix it, and at the same time, have the patient understand what we're doing. That's my goal.
Would the high spike, can that be reduced or mitigated by spreading the meals out, more meals?
Yes, it
in
can.
Smaller doses?
That's a great comment. You know, when I was newly minted as an endocrinologist in 1992, we used to talk about grazing diets. You know, grazing versus like a cow, just, you know, grazing versus gorging. You know, 1 meal a day. And the funny thing is that the thinking has come about face, and now we think that it may actually be more healthy to have 2 moderate meals or 1 big meal a day, as long as we choose the right foods when we have that meal. Because when we're fasting, our body's ability to make insulin can regenerate. So, you know, you hear about keto diets, you hear about fasting mimicking diets, 16-hour fasts. They're not just fashionable, they make scientific sense. So it's not necessarily wrong. And I know, for instance, that Ramadan is coming up.
Yeah.
And, you know, the Muslim people aren't allowed to eat during daylight hours. Well, this time of year, that's very long. So they're fasting quite a bit. And providing that they don't go overboard when they break their fast, it may actually help their diabetes.
But I was stopped by my doctor from having these fasting in Ramadan sessions.
Yes. So, Rudin, that's all changing. So I'm actually going to put an article up on the website on
That would be
Ramadan
interesting,
and
yeah.
the approach to it. So rather than using long-acting insulin, which is what we did in the old days, I think we're concentrating more on using fast insulin. Here we've got another tracing. The first thing we're looking at, don't ignore what Dr. Elliott said at the title of the slide. Is there a problem with low sugar?
No.
No.
I agree. There's some, but we're not worried about it. What do we see overall?
It's high.
Generally high.
We see high sugars, waking, and you know, apart from
4 o'clock.
after, I think that's a late lunch. Who knows what that is? The sugar goes up and then they come down.
Yeah, but the spike is not all that pronounced.
Yeah. I can't remember this case exactly what's going on, but I would wonder that there's too much insulin there. I mean, the sugar stays within the target, but it's dropping a lot. My concern is that the patient wakes up with a high sugar. So in this person, providing that they're being good, diet and exercise, I'm going to put them on a basal insulin, once a day long-acting insulin, and if they're already on it, then we're gradually going to increase the dose. And we might have to watch out what's happening here. Maybe they're taking too much of the fast insulin there.
What would cause a person to wake up with high sugar?
Well, as I mentioned, you can wake up with high sugar because your liver is making too much sugar. That's very common in diabetes.
Liver?
The liver, yes, the liver. Now, what about here? What do you think's going on here?
Midnight snack.
Yes, something is happening at 8:30. So I say to the patient, what happens at your place at 8:30? Well, you know what? I work long shifts. I get home. I'm exhausted, and I just can't stop eating. I sit down in front of the TV, and I just can't stop eating until I go to bed. So, what's the treatment of that? The treatment of that is, if you're exhausted, go to bed. Don't eat. And if you're going to eat the right things. And if you're eating the right things, then you need some fast insulin. So maybe the high sugar in the morning could be fixed by changing the evening meal or taking rapid insulin there. So all of these considerations are relevant. Like there's no wrong answer here. As long as we avoid low sugars and gradually reduce high sugars, we're winning. Okay, does anybody want to have a go at this one? I'll tell you, this patient's on too much long-acting insulin.
Yeah.
It's the commonest pattern we see. We know it's long-acting because the problem is first thing in the morning when they're fasting. And the reason long-acting insulin is such a problem is that until this CGM Freestyle Libre revolution, as doctors like me, we used to give people long-acting insulin. Keep taking more and more and more until your sugar's between 5 and 7. So in this case, we have to back off on the long-acting insulin, and then we have to maybe do something about the mealtime, but this is actually not bad. The patient's between target except in the morning where they're low. So too much long-acting insulin, that's been the culprit half the time, hasn't it?
Right.
Okay, I've called this one up and down like a mountain range. Patient, there are some lows, not a lot. There are these massive highs in the morning. The sugar starts to go up at about 5 o'clock. So this person's got the morning shift. They eat a lot, they have lunch, they have an early lunch, the sugar goes high. The sugar comes down in the afternoon, and then they have dinner. So we're back at the same point of, is the problem with what we're eating? Is the doctor not giving the right doses of insulin? Well, I'm pretty sure it's a combination of both. So when you're at home with your Freestyle Libre, I don't want you to wait 2 weeks to look at the results. I want you to look day by day. With your devices, you can easily scroll back and see what's happening. If you see a pattern, you don't need to wait till you come to the appointment with me. I want you guys to be proactive.
But you know what I found very useful with it is I'll eat, for example, a banana, and then I'll check like every 15, 20 minutes, and I'll see, oh, okay, over the hour, the banana only put me up 1.5
millimoles. Yeah.
millimoles. No, so now I know if I eat a banana, I don't have to worry.
Yeah, yeah. And that's right. So you know, if you see a dietitian, the dietitian might talk about carb counting. Carbs are starches, and you know, there are rules of thumb that most people will need a certain amount of insulin for a certain amount of starch. And so when you get technical, you can start being very, very specific about it. You know, you can either eat the same thing every day and figure out the right insulin doses by trial and error, or you can be scientific about it and base your rapid insulin on how much carbs you're eating. A lot of people need 1 unit for between 5 and 10 grams of starch. So if you're having a Big Mac and fries, that's about 100 grams of starch. And then if you need 1 unit for every 10 grams of starch, a Big Mac and fries 100 divided by 10 is 10 units. You would take 10 units of fast insulin. If you need 1 unit for every 5 grams of starch, 100 divided by 5 is 20 units of rapid. Lots of people with type 2 diabetes need 1 unit for every 2 grams. So that would be 100 divided by 2 is 50 units. So as long as you're being methodical and avoiding low sugars, you can gradually increase the dose to figure out what you need. This is the same pattern we've seen time and time again. The sugar's low in the morning. What's the treatment, Ron?
Less long-acting insulin.
Less long-acting insulin, exactly. This, I can tell you about this patient. The first thing you notice is that there are no lows, and almost all the sugars are high. And I can tell you, this person came to see me from their family doctor. They were on no medication, and I told them about a prudent diet. A prudent diet is, you know, doing what you can. Imagine you're going to live to be 90. Well, no point in, you know, eating cardboard or eating a ridiculous diet just to lower your sugar. Eat what is reasonable and see what happens. And sure enough, he followed a good diet, no medication. His sugar's sky high. Well, I had no difficulty in telling him that he needed medication. So I can't remember what we did. I think we put him on some pills. Typically we would start with metformin. We would add an SGLT2 inhibitor, and only time will tell what he needs. We could just as easily have put him on basal insulin, and that would have just brought down the graph. Okay, now, this is a tricky one, and I've put it in here for the physicians and diabetes nurse educators out in the internet. You can see that this person's sugar starts to go up at 4:30 in the morning. And I should add, it goes fairly low before then. And I said to her, "What time is breakfast?" And she said, "Oh, breakfast isn't till about 8 o'clock."
Yeah.
So her sugar is going up long before she eats. So, Sadruddin, this could be her liver making sugar. It might be another phenomenon called the dawn phenomenon, where from dawn onwards, in some people, their bodies make a lot of growth hormone and cortisol hormones that raise the blood sugar. The other possible cause is that these low sugars, she is taking basal insulin, so her sugar is low and her body goes into overdrive, raising the sugar, but oversteps the mark. And that's called the Somogyi effect.
What
So,
effect?
Somogyi is a Hungarian doctor, Somogyi. We hardly ever see it, but it makes me think of it. So what we need to do is, number one, make sure she doesn't go low. So if that pattern is still there and she's not going low, it means it's not the Somogyi effect. Maybe it's the dawn phenomenon. And then we need to give her something that'll combat that. So we ended up putting her on some old-fashioned insulin called NPH insulin. And of course, you know, here she is running low a lot as well. So bottom line is, I think that she had a combination of too much long-acting insulin with a bit of a rebound and then some dawn effect. So she's on way less long-acting insulin and more fast insulin.
All these factors probably are also affected by the fact that a person is older, heavier set in weight, or has some ethnic heritage.
White, lean, and 65. So you know, we can't. I mean, it's nice to make a stereotype, but no, none of those things were going on, Sadhruvan.
I just read somewhere. That's what
Yeah.
I'm trying to bring it to.
Yes, yes.
Yeah, I mean, I've read this, so
Yeah,
I don't know how true it is.
yeah. Okay, what about this one? Dr. Elliott says, hi after lunch and after dinner. Number one, there isn't a problem with low blood sugar. The person's waking up with decent sugars. The problem is here and here. What are the options, Rosalia? If you're too high after a meal, what can you do about it?
Lessen the amount of what you eat.
Eat less?
Eat less, yeah.
What about changing what you eat? What if you eat brown rice
Yeah.
instead of white rice?
Yeah.
Does that help?
It helps, but also you have to consider the quantity.
Okay.
Yeah.
Because
Because that's what I'm
people
doing.
eat brown rice?
Yeah, now I eat brown basmati rice with quinoa.
Okay.
Yeah, that's why but if I eat a lot of that, it doesn't work too. It will be high for
If you eat a lot. So yeah, it's not just what
Not
you
just
eat, it's the quantity.
the quantity.
So we can use dietary intervention, we can use pills, we can use fast insulin, we can use one of the GLP-1 agonists. And that, ladies and gentlemen, is the end of the presentation. For the purposes of of Facebook Live, I think we'll finish up here. Thank you very much, audience, for staying with me. And I don't think we allowed questions at this time. But on future events we will allow questions. So thanks very much. Ron, could you